Patel, please.
My paper is cervical epidural anesthesia for clavicle surgery in a patient with a clavicle fracture with multiple rib fracture. I got three components in my paper. One is cervical epidural anesthesia, rib fractures, clavicle fracture and surgery. First, let me talk about the cervical epidural anesthesia. This technique can be used successfully for procedures involving neck and upper thorax, and less commonly practiced due to concern of potential complications such as dural puncture and paralysis of respiratory muscles. However, in the hands of expert anesthesiologists, the risk associated with these complications is low. Cervical epidural blocks the cardiac sympathetic fibers and consequently decreases the heart rate, cardiac output and contractility. The mean blood pressure is unchanged or decreased depending on the peripheral systemic vascular resistance changes. Baroreflex activity is also partly impaired. The potential specific complication mainly cardiovascular and respiratory because of the exacerbation of the effects of cervical epidural. Side effects such as bradycardia, hypotension, acute ventilatory failure in relation to respiratory muscle paralysis may be observed, but close monitoring of hemodynamics, respiratory rate and level blockade is required. So cervical epidural anesthesia may be used either alone or combination with the general anesthesia depending on the surgical procedures. Number of prospective and retrospective studies have compared the frequency of both perioperative and postoperative complication, and results from some studies suggest that cervical epidural, the morbidity and mortality rates were low and the hemodynamic variables better maintained. This technique offers the advantage of better and early postoperative recovery and reduced incidence of postoperative cardiorespiratory complications. Coming to rib fracture. Rib fracture is the most common injury from the blunt chest trauma, and fracture itself generally doesn't require any specific treatment, and therapy is directed at minimizing pulmonary complications secondary due to the pain, splinting, atelectasis, hypoxemia and pneumonia. Elderly patients aged more than 55 with rib fractures have twice the mortality and thoracic morbidity of younger patients with similar injuries. So epidural anesthesia should be used liberally in patients with severe pain, the elderly and the patient with the pre-existing compromised pulmonary functions. There are data support of 6% decrease in the morbidity and mortality, and endotracheal intubation is reserved for patients who are unable to oxygenate or ventilate to require protection of airway. Advantage of epidurals in rib fractures: superior anesthesia with increase in FRC, dynamic lung confidence, vital capacity in PaO2, reduction in airway resistance, and change in shallow breathing to near normal, and reduce the paradoxical chest wall movement and modify immune response. Disadvantage: technically demanding, it may mask intra-abdominal injury, cause hypotension, CS instability and other side effects. And coming to clavicle fracture, fracture of clavicle account for 4% of all fractures and 35% of fractures in the shoulder region. Majority of clavicular fractures can be treated non-operative methods, and clavicle surgery are usually done under general anesthesia or regional nerve blocks. But complication rates following displaced clavicular fracture in adults and elderly patients shows that outcome in these patients are much less satisfactory, and non-union, malunion of clavicular fracture can lead to variety of undesirable outcomes. It leads to increasing recognition of adverse outcome following a fracture has led to internal fixation of displaced clavicular fracture in adults. There are some indication for internal fixation of clavicular fractures. And finally, coming to case report. 65-year-old male admitted with history of fall from bicycle. He had complaining of pain over left side of chest and left shoulder, and he was complaining of difficulty in breathing. Respiratory was 32 per minute, SpO2 87% room air, but hemodynamically was stable. Chest X-ray showed middle third community fracture of clavicle left side and fracture third, fourth, fifth and rib left side. These are chest X-ray showing clavicle fractures. This is a patient, you can see the skin tenting also, and third, fourth, fifth rib fractures. And the patient is posted for ORIF clavicle. Pre-anesthetic examination, routine investigations were normal. Respiratory system breath sound decreased in the left infrascapular region, and crepitations over the same area. SpO2 88% on room air and with 4 liter oxygen. 94%. Written informed consent taken nil early 6 hours pre-op. What options we had? We had general anesthesia with intercostal nerve block, or a combination of interscalene brachioplexus block or superficial cervical plexus block. But what we did, General anesthesia risk were weighed against the benefits and the need for the multiple injection for regional nerve blocks for the clavicle fracture repair and the analgesia for rib fracture. So even nerve blocks differ and we planned for cervical epidural anesthesia. On the day of surgery, after taking informed consent, explaining the procedure to the patient, routine monitors oxygen given 5 liters per minute, midazolam, and cervical epidural anesthesia was performed with the patient in a sitting position, C70 one space, local lignocaine given, 18 gauge storage needle, loss of resistance technique, and catheter is 3 cm cephalad. After negative aspiration of blood and CSF, 3 ml of lignocaine with adrenaline test dose given, and 12 ml of 1% lignocaine with adrenaline with the 3 ml of increments given. This is sitting position and with the catheter is fixed. The onset of sensory block assessed with a pinprick test every 5 minutes for 30 minutes after local anesthetics, and 30 minutes after local anesthetic skin incision was made. The patient had adequate surgical anesthesia from C3 to T6, vitals remained stable and there were no intraoperative problems and surgery was completed within 1 hour. This is the ORF of clavicle. And patient was awake, comfortable during intraop and postoperative period. Postoperatively buprenorphine 150 mics 12th hourly given with 10 ml of normal saline and bupivacaine 0.125% 6 ml 6th hourly for 3 days. And his respiratory rate becomes normal and he was comfortable in postoperative period also. And after reviewing the literature, we found that there is no case of clavicle surgery is done under cervical epidural anesthesia. So maybe this is probably first case of cervical epidural anesthesia for clavicle surgery. And clavicle surgery can also be done under cervical epidural anesthesia, and it's safe and effective to alternate to general anesthesia and regional nerve blocks. And larger studies are required to support this. These are some of my references. Thank you.
I have no experience using cervical epidural for clavicle fracture. I guess the question I have is, yes, it can be done. Should we do it? And as you said, we need more data and look at safety and all that before we can recommend something like this. Whether it's better to use other techniques and other choices.
Thank you, Dr. Yogesh.
Thank you.